Well, thank you very much. I'm really honored to be here. This is an amazing group, and it's really, really wonderful to see everybody so dedicated to this project, and thank you for your interest in our research. Ira pretty much covered most of my opening remarks in terms of how we got to where we are, and how there's a lot of extensive research that's been done over the past 25 years that we've talked about all morning, showing the effects between dental care and systematic health, but it's largely focused on that private payer population. And in the Medicaid population, we see people who are much more, struggle with many more health care needs, they're lower socioeconomic status. It's a very different population. And so we set out not necessarily to replicate the prior findings, but to really look into this Medicaid population and see what those measurable effects were between the utilization of dental care and then the healthcare outcomes, including costs. Before we get into the study methodology, I want to make sure everybody has some familiarity with the Medicaid program in New York State. It's one of the largest in the country. It actually provides health insurance to about a third of all that have health insurance in New York State. And it covers about 1/2 of all people that have disabilities, 1/2 of low-income New Yorkers, and 2/3 of all in nursing homes. About half of the population is an adult population. And since 1997, the program's been moving from a fee-for-service model to a managed care model, solely bringing in all of the different populations with their complex healthcare needs into managed care. And today, dozens of different managed care plans, from generalized plans to specialized plans, provide the healthcare for the New York populations on a mandatory basis. Enrollment is mandatory, and we have HIV care covered, behavioral health specialized plans, substance abuse and disabilities plans being developed. Our expenditures are very, very high. It's second only to California in terms of the total state budget, with about a third of our state budget being spent yearly on our Medicaid program. And the dental benefit package happens to be one of the most robust Medicaid dental packages in the country. Even so, it's not considered a comprehensive package. It is an essential services package. It focuses largely on the preventive care and maintenance with flexibility to address serious health conditions. Includes inpatient diagnostic dental work, palliative, and therapeutic dental care. And of course, we have to talk about exclusions from a dental package. So some of these services on this slide, or the services rather on this slide, are not covered, but I would like to note, you can see some asterisks across those services, that there is flexibility on a medical need basis. So a lot of these, a lot of cases can be reviewed directly with the program to receive authorization for the services to be provided as needed. And because we're looking at utilization of the services, we have to talk about the allowances for the services. In terms of prophylaxis and maintenance, that's once every 6 months. Members are allowed to receive those services, though not in conjunction with each other and not on the same date as a root planning and scaling event. And for treatment, endodontics do require prior authorization. Surgical procedures are based on severe hyperplasia or hypertrophy associated with drug therapy, hormonal disturbances, or congenital defects. Root planning and scaling, I'll point out, it's just a limit of every 2 years per quadrant, and some of the extractions do require prior authorization as well. So those were the treatments that we really looked at and the allowances accordingly. Which brings us to how we framed our study. And we strategically looked at a 3-year period from 2012 to 2015, and the reason we chose those dates is because in 2012, the dental benefit became mandatory for the managed care plans to cover. Prior to that, they had the option of providing that as a benefit, with their capitation rates adjusted accordingly if they were going to, but enrollees of plans that chose not to cover it would receive their dental benefits on a fee-for-service basis. So this kind of gets into clean data. It was claims coming into us versus now they're encounters through managed care organizations after 2012. So that cleaned up the data for us by starting in 2012. We allowed 6 months for some leeway for data input issues and things that happen, processing and what have you. 2015, many of you will know the ICD-9 coding system changed to ICD-10, and even though we ended up using CRGs, it's still, for data cleanliness and consistency, it does remove some more of those administrative confounders, basically, and cleans up the data by stopping at 2015. The population, we wanted to look at the older segment of the Medicaid population. Of course, Medicare kicks in at 65, and as that's a federal funded program, we don't have access to all of those data readily. We don't have linkers to put the two programs together if we did request that. So we excluded those people who were duly eligible for Medicare and Medicaid at the same time as well for that reason. And it's important to note that this is a continuously enrolled population. Of course, if we're going to look at the services utilized and the outcomes in this population, we need to know we have record of all of the transactions that happened during the study period. The continuously enrolled population, mind you, is not necessarily representative of the entire Medicaid population as a whole. This is the subset of the population that did not have circumstances improve enough for them to become uneligible for Medicaid during a 3-year period of time. So I'd just like everybody to keep that in mind, that our cohort is a very different subset of the Medicaid population. We also ended up excluding residents of long-term care facilities that would not routinely provide dental care, such as a hospice setting, and also facilities in which there were rate codes that were used for the billing so that we wouldn't actually be able to tell what services were provided. And in terms of outcomes, this is set up as preliminary findings, and it's really less preliminary findings as much as where we are to date with the study, because we have a lot more work to do. But to date, we've been looking at the emergency department visit rates, hospitalization rates, and then costs in the categories that you can see here, including emergency department visits and pharmacotherapy and total health care costs. And the comparisons we make of those outcomes are based on dental care utilization, and as was just alluded to previously, we don't have diagnosis codes for periodontal disease, so we don't have a cohort that we know has untreated disease or anything like that. We do know that we have a part of the population that's not utilizing dental care, and we wanted to use those as our reference group and then look at the impact of having preventive care with anti-infective therapy, preventive care without anti-infective therapy, and anti-infective therapy in the absence of preventive care. And so we looked at the Medicaid transactional data to identify the people that fell into these different groups. We put them in the buckets and then looked at their outcomes. And after we did that, we repeated everything, focusing in on only those people with certain the NCDs of interest. The cardiovascular disease, diabetes, respiratory disease, and cognitive impairment are the ones that we started with. To identify people as having those conditions, we use the 3M CRG clinical risk grouping software, which is how the Medicaid program in New York does rate adjustment and risk setting for populations. It's extremely robust. It's a gold standard logic model for risk adjustment, as it factors in not just diagnoses, but also utilization of healthcare services, including pharmacotherapy, and can even get into the severity of someone's illness within certain categories. Which brings us to our analysis, and the demographic piece, we've been looking at the demographic makeup of all of the comparison groups as we move along. We've also started to take these deep dives into subsets of the population that we see that are managed long-term care users, that are high utilizers of extensive skilled nursing facility care in the community and things of that nature, people with different mental health and behavioral health issues, alcohol, substance abuse. We're looking at the demographic profiles of these people to kind of see what's driving the results that we saw. The cross-sectional analysis piece started off really just to look yearly to see if there was any macro-level changes in what was happening in the system in terms of the rates of ED visits or the cost of prescription care, cost of hospitalizations, and to see if there was something that would be confounding what we were seeing when we tried to make the association between dental care and the outcomes. Ira will show you a snippet of our cross-sectional results from the first year, just so you can kind of get a sense of what the climate looked like, even in the absence of temporality between dental utilization and the outcomes. But then to get that temporality piece, we wanted to look longitudinally. And so the way we approach this, or have to date rather, is to look at somebody's healthcare utilization over the first 2 years and develop those comparison buckets based on their dental care utilization in years 1 and 2 of the study, and then follow the people into year 3 to see what their health outcomes looked like after we could group them into the dental care utilization groups. Most recently, we started to look at the impact of increasing frequency of preventive care, and the point was just made that the people who in the private payer settings that utilize preventive care visits twice a year often are very compliant with their health. But interestingly, I think that as we start to dive more into the Medicaid population, what we see is people who utilize preventive care services or are rather in compliance with what's prescribed to them, have high levels of care management. They're not necessarily making these decisions on their own. They're not necessarily a more healthy population. It's actually really difficult to move the needle in this population, and so it is a different group of people. But yet, as Ira will show you momentarily, we saw some really compelling effects of just using preventive and dental care treatments as well in the cohorts, especially when we get into NCDs. So with that, I will hand it over to Ira to go through our findings to date.